Hi, everybody. It's September 16th. Welcome to our grand round, second ones for this year. We've got Dr. Jessica Jackson today going to speak to us about febrile neutropenia. I'll let you take it over.
Sounds good. So thank you so much for having me here today. So I'm going to be talking about febrile neutropenia and an updated approach to both inpatient as well as outpatient management of this common complaint that we see in our oncology population. So just in terms of disclosures, I have absolutely nothing to disclose. Just to start off a little bit about who I am. So I completed my internal medicine core residency and then my general internal medicine subspecialty training, both at Western University. My claim to the north is that I was born in New Liskeard, but I was fully raised in Southwestern Ontario. But myself and my husband relocated up here to Sudbury about 2.5 years ago. And I currently work both in the departments of general internal medicine as well as oncology here at Health Sciences North. I have some special interests in perioperative medicine, obstetrical medicine, benign hematology, and oncology. So I spend quite a bit of time taking care of inpatient oncology patients. So frequently encountering febrile neutropenia, both as an admission from the emergency department or the oncology suite, or as a complaint that arrives during a patient's visit to the oncology ward for an alternative reason for admission. So my objectives today are to review the definition of febrile neutropenia, review the approach to the neutropenic patient, epidemiology of common pathogens, review a few tools that help us determine whether a patient should be managed as an inpatient or an outpatient, and then review the management of febrile neutropenia patients, including antimicrobial choice and duration of therapy. And there's a few case examples we'll go over as well. So the first case that I wanted to bring up, and we'll cycle back to this case at the end once we've talked a bit more about febrile neutropenia, is a 42-year-old female with ovarian cancer on every 3-week carboplatin and paclitaxel chemotherapy. She last received chemotherapy 5 days ago. She was taking her temperature daily at home as instructed, and found to have a temperature of 39 degrees Celsius. So she presented to her local emergency department for assessment. And sorry, I should mention, if anyone has any questions at any point in time, please just put your hand up and I'll try to get to them as we go, and we'll have some time for questions at the end as well. At the time of her presentation, this lady was asymptomatic. Her history and exam were negative for any clear infectious source. Her vital signs were all stable. She was still febrile and she was saturating well in room air. And her investigations revealed a hemoglobin that was slightly low at 112, a white blood cell count that was suppressed with a neutropenia with an ANC count of 300 and platelets of 78. But otherwise, all of her blood work, electrolytes, creatinine, liver function tests, and liver enzymes were all unremarkable. And then the second case that I'd like to talk about is just an interesting one that I recently saw on the ward, interesting in how it evolved and what it looked like. But this was a 64-year-old gentleman with a history of myelodysplastic syndrome, not currently on therapy. His past medical history was significant for his myelodysplastic syndrome, type 2 diabetes, which was relatively well controlled on oral agents, and some mild hypertension. And he again presented after finding a fever at home. He was asymptomatic. His history and exam was again negative for a clear infectious source. He was quite concerned because he was actually booked to undergo an allogenic stem cell transplant for his MDS in 3 weeks' time in Ottawa. And so he didn't want anything to kind of delay that treatment. He was vitally stable as well, a little bit fast in terms of his heart rate. Temperature was febrile, and he was saturating well in room air. And his investigations revealed a pancytopenia that was very stable from his prior count. So a hemoglobin of 72, a total white blood cell count of 1.1 with an ANC of 100 and platelets of 24. And he had kind of for years had cell counts that looked similar to this. In fact, those platelets were actually quite good for him. And his other investigations were relatively unremarkable, with the exception of a mildly elevated glucose of 17. So we'll cycle back to both those cases at the end. But the first thing to talk about when we talk about febrile neutropenia is the definition of febrile neutropenia. So there's two components to that. There's obviously the fever and then the neutropenia itself. So in terms of the fever, there's lots of definitions floating around out there. It depends on what country you're practicing in, where you're taking the temperature on the body, but the IDSA's definition of fever, specifically in the context of febrile neutropenia, is this one. So that's what I'm going to be using for the duration of this talk. And also most of the studies for febrile neutropenia and guidelines use this definition. So it's an oral temperature of greater than or equal to 38.4 degrees Celsius, or an oral temperature of greater than or equal to 38 degrees for more than 1 hour. The reason it's an oral temperature is that that's the easiest to take for most patients at home, because often they're asked to take temperatures at home monitoring themselves. There, you can, as an alternative, sometimes use a tympanic temperature if a patient has really severe mucositis. That'd be probably the only reason not to use an oral temperature, and just avoid any rectal temperatures in these patients, because we're trying to avoid inserting anything into the rectum in our neutropenic patients. In terms of neutropenia, the actual diagnosis of neutropenia occurs when the neutrophil count is less than 1,500 cells per microliter. But we really don't get concerned about neutropenia until it's severe, which is at less than 500. Okay, and you'll see this often reported on your CBC as your 1,500 would be 1.5, and your severe neutrophil count would be 0.5. Okay, so that's typically how it's reported on Canadian CBCs, and an ANC just means an absolute neutrophil count. So when we refer to that acronym, that's what we mean. And so 500 really is the cutoff where patients are at increased risk of catching infections and having poor outcome. In fact, 500 is often the cell count we are looking for in order to discharge a patient when they're in hospital for induction or consolidation chemotherapy. So in terms of causes of neutropenia, there are numerous causes of neutropenia. The ones that we always think about are patients with hematologic malignancies or patients on chemotherapy. So these two top categories certainly are the ones that get admitted to hospital most frequently with febrile neutropenia. So your hematologic malignancy, your acute leukemias, hairy cell leukemia, LGL leukemia, myelodysplastic syndrome, like in our second case, and then medications, anything cytotoxic, typically chemotherapy is what we mean by that. And then any medication that can cause agranulocytosis as a side effect potentially could cause neutropenia as well. But just remember, there are also other causes of neutropenia, and these patients are also at risk of infection. So ironically, some severe infections and some viral infections can cause pancytopenia and neutropenia. So HIV, hepatitis, EBV, and then severe sepsis. Rheumatologic conditions can cause neutropenia, sometimes associated with the therapy they're on for the rheumatologic condition, and sometimes independent of that. It's most common with lupus patients and rheumatoid arthritis patients, aplastic anemia patients, and then there's a few conditions that are very rare and typically associated with certain ethnic backgrounds. The DNAC is common in Black African-American populations. Familial neutropenia is in other ethnic groups and runs in families. And then there's a certain percentage of the population that just chronically has idiopathic neutropenia. And those patients are just at that end of the bell curve for normal, with no pathologic reason identified. So again, the top two causes that we see most frequently, and we certainly think about when we think about febrile neutropenia, are the hematologic malignancies and patients on chemotherapy. So we're going to focus mainly on those case examples today, but just be aware there are other potential causes of neutropenia that we certainly need to pay attention to those patients as well and investigate them for A, their cause of neutropenia, and B, to make sure they're appropriately counseled on what to do if they were to get a fever. So febrile neutropenia is actually quite common in our oncology patient population. Studies estimate that up to 50% of patients with solid tumor malignancies and up to 80% of those patients with hematologic malignancies will receive, will develop febrile neutropenia at some point during their systemic therapy. And this is certainly what I see on the wards. Almost all patients that are admitted for an acute leukemia or other hematologic malignancy, whether it's lymphoma, leukemia, myeloma, will develop a fever at some point during either their induction or consolidation chemo or their stem cell transplants. So it's much more common in hematologic malignant patients, but certainly can occur in solid tumor malignant patients as well. And febrile neutropenia is for sure one of the most serious complications of chemotherapy. And the mortality rate is as high as 11%. So something that is risky for these patients. And in terms of chemotherapy, certainly one of the most serious complications. So in terms of your approach to the neutropenic patient, this is going to be very similar to your approach to a patient with sepsis, but there's a few things that I just like to draw your attention to that you should focus on in an oncology patient or a neutropenic patient specifically. So the first thing you're obviously going to do when you see a patient who you suspect is neutropenic is to ensure that they are stable. You want to document their temperature for us so that we know for sure it's not just a temperature they received at home, but that we have a temperature on the medical record here of truly documenting febrile neutropenia. Insert IVs, start IV fluids, etc. Then you want to send off your initial investigations. Those would be your routine blood work and chemistries. But in addition to all of that, you want to ensure both aerobic and anaerobic cultures are taken. Please take a culture from any indwelling central line, whether it's a portacath, a PICC line, even an IV that's been inserted for some reason as an outpatient. Make sure those are cultured. A urine culture, even when asymptomatic. This is one case where I would suggest a urine culture. And then a chest X-ray and a COVID swab. These days, anyone with a fever should have a COVID swab. We're all aware of that. Certainly, these patients are equally, if not at greater risk of developing COVID infection as the rest of us. And then empiric therapy should be started before you have necessarily the results of all of your history and physical completed or your blood work results returned. They suggest in the guidelines that you should start empiric therapy within an hour of the patient's presentation. This is mainly a guideline recommendation based on surviving sepsis guidelines. There haven't been a lot of studies specifically looking at the mortality rate in terms of timing of antimicrobials in this patient population. But most of the guidelines across the international societies, certainly the IDSA guidelines, suggest antibiotics within the first hour of patient presentation. So the same time that you're doing those things, you're sending off your blood work, you're starting empiric therapy, you're going to obviously do a history and paying particular attention to a review of systems for infectious symptoms, sick contacts, their COVID vaccination status, and then the date of their most recent chemotherapy, because that will give you an idea of where they are on their nadir for their white count, whether they are just at the start of their counts dropping, if we're expecting a recovery shortly, and just in general, give you a sense of the duration of time they're likely to be neutropenic. In terms of the physical exam, the things I want to highlight is that you want to make sure that you examine their ports, their central lines or IVs for signs of infection. You want to do a good oral, nasal, pharynx examination and mucosal examination looking for mucositis. And you want to avoid a DRE in these patients. And then once you've completed your history and physical, you're obviously going to adjust your antimicrobials according to anything that you found that may localize that infection on your history and physical. Okay, so this is just a couple examples of things, again, to pay particular attention to on your physical exam for these patients. So please look in their mouth for mucositis. Absolutely can be the cause of a fever in these patients and is very distressing to them. And then the PICC line infection, I mean, looking for signs of erythema, purulent discharge, signs of infection there. So in terms of choosing your empiric therapy, because I just told you that the guidelines would suggest that you do this within an hour of seeing these patients. It kind of depends on whether this is a low or high risk patient in terms of what you will select for your empiric therapy. And so we'll go more into detail into that. But before we can even discuss what empiric therapy should look like for these patients, I think it's important to actually review the epidemiology of what the cause of the infection is, so that you can understand why the empiric therapy that's recommended is what's being recommended. So the one really important thing to know is that all of the evidence related to pathogens is somewhat limited by the fact that an infectious cause is only identified in about 20 to 30% of all cases of febrile neutropenia, and a bacteremia is only discovered in about 10% of cases. So all the studies that look at the epidemiology, trying to discover where the source of infection is limited by the fact that the vast majority of cases will have no localizing source of infection, and their microbiology results in terms of blood and urine cultures will likely be negative. So this is our best guess based on the results that we do have back of people that are bacteremic or have an identifiable source of infection on clinical exam. It is thought, though, that most of the pathogens that cause febrile neutropenia are likely related to the patient's own flora, especially skin flora, oral flora, and gut flora. Not as much genitourinary infections, but specifically skin, oral, and gut are where we think most of the cases of febrile neutropenia come from. So in terms of pathogens, there's obviously bacterial, viral, and fungal that you need to consider. Bacterial is the most common. It was classically taught, and even in my residency training, which was not in the 1980s, I was taught that gram-negative organisms were the predominant pathogens. But that definitely has changed in more recent years. So more recent studies have shown that gram-positive organisms are actually the most common. And that's probably because of a few things. So number one, oncology patients are far more likely to have indwelling central lines that remain in situ for the duration of their therapy these days. So whether it's a PICC line, a portacath, et cetera, they have something in their body that is more likely to be colonized with a gram-positive organism than gram-negative. It's also part of routine practice for many patients to be placed on prophylactic medications to prevent febrile neutropenia. And the most common medication used is ciprofloxacin. And so that would hopefully prevent a lot of gram-negative infections as presenting as febrile neutropenia. And that probably self-selects for more gram-positive organisms being isolated when patients present with issues. So there's a combination of reasons why we've swapped from the predominant organisms being gram-negative to gram-positive, but just be aware that gram-positive coverage is equally, if not more important to gram-negative for these patients. So the most common gram-negative pathogens are the ones you would expect. E. coli is the number one most common culprit of gram-negative, Klebsiella, Enterobacter. I'll draw your attention to Pseudomonas just because it tends to have some of the worst outcomes if patients are bacteremic with Pseudomonas. And then your gram-positive pathogens are, again, the similar ones that we see in general medicine practice. So coag-negative staph, we need to be careful. It's not a contaminant in these patient populations. Staph aureus, both MRSA and MSSA, Enterococcus, Viridans group strep, which often comes from the mouth, strep pneumoniae, and then group A strep, so a skin organism. And then viral pathogens are certainly out there, but often we don't find, these are cases where we don't find or localize a pathogen. So the common respiratory illnesses, influenza, COVID is a new consideration. Certainly lots of patients present with a fever. It turns out to be COVID and they happen to be neutropenic at the same time. But do remember that rare viruses impact our immunocompromised patients. And by definition, these patients are immunocompromised. So active or disseminated HSV, VZV infections, EBV, CMV are all things to consider when you're doing your exam, making sure you're doing a thorough skin examination for vesicles and that sort of thing. In terms of fungal infections, these are common in high-risk patients, but very uncommon in low-risk patients. So the risk for invasive fungal infections increases with the duration and severity of the neutropenia, prolonged antibiotic use, and the number of chemotherapy cycles. So clinically, the patients we see who develop fungal infections are typically patients that have been admitted to hospital for multiple rounds of induction and consolidation chemotherapy or stem cell transplant patients. They're not typically your solid tumor patient that comes in with a fever after a round of chemotherapy. So they're very rarely the cause of a first episode of febrile neutropenia. It's more likely to be patients that have been in hospital for an extended period of time or have been severely neutropenic for an extended period of time. But there are a few fungal infections I'll just highlight for you to be aware of, because as you can imagine, fungal infections are incredibly dangerous. And if we miss them, then patients are likely to pass away, have high mortality rates, and we don't deal with fungal infections that frequently in medicine. So just as a reminder, these three are probably the ones to be most aware of. Candida infections are common in neutropenic patients. The source is thought to be the GI tract, with translocation across damaged intestinal surface when patients develop colitis or mucositis as part of their chemotherapy side effects. And Candida albicans is still the most common, even in patients on fluconazole prophylaxis. And candidemia is something that can present in these patients with minimal symptoms. So if you see someone with Candida in the urine who has a catheter, the treatment is still just to change that catheter. It's not to treat them for systemic Candida infection, but keep Candida in the back of your mind for someone who is persistently febrile neutropenic or febrile and has been neutropenic for an extended period of time. Invasive aspergillosis infection is probably the most common pulmonary infection that we see from a fungus perspective. It can affect both upper and lower respiratory airways. And you can diagnose this via some classic imaging findings, a serum galactomannan assay on blood work, or even bronchoscopy if you can access that locally. And then mucormycosis is a life-threatening infection that can typically affect the mouth, the orbits, the nasal passages, and can cause disseminated infections, and is most common in patients with poorly controlled diabetes. So for Candida, generally patients who are candidemic, so Candida in the blood, are generally relatively have nothing to find on physical exam, but can occasionally develop an erythematous nodular rash. So there's something to think of if you see people with weird rashes. Aspergillosis, this is the classic halo sign, which they'll describe on CT as being very classic for invasive aspergillosis. So that kind of haziness around a central nodule on pulmonary imaging. And then mucormycosis is the classic textbook photo that everyone talks about, the black eschar that starts either in the nose and works its way up into the orbits, or is affecting the sinuses in some way. This is typically diagnosed often by ENT, needing to go in and look in the nose, take scraping, send it off for culture. Or microscopic evaluation, and can be quite life-threatening if you think someone has mucormycosis. So again, that's reviewing the pathogens. So again, bacterial is most likely, viral is out there and certainly possible, and often we don't actually find the actual etiology unless you have a good viral panel done and you happen to be lucky and pick up something like parainfluenza. But often a viral infection just kind of is a fever that we can't localize. And then fungal infections are certainly possible, mostly in high-risk patients who have been neutropenic for an extended period of time. In terms of empiric therapy, let's go back to that. Now that we know what pathogens we're focusing on, I've told you that we should initiate empiric therapy quite quickly for these patients within an hour of their presentation. So what should we be choosing? So again, empiric therapy depends on whether or not you think this is a low risk or a high risk patient. And there's been a few scoring tools that have been developed over the years to help us assess whether this patient is at a low risk of developing severe complications of neutropenia or a high risk. And not only does this dictate empiric therapy choices, but also whether this patient is appropriate to be managed as an outpatient versus needing to come in for an inpatient stay. Okay. So the first scoring tool that I'll just bring your attention to is an MASCC risk score. So this was developed to try to identify patients at low risk for febrile neutropenia complications. So there's several characteristics they look at. So the burden of illness, if they have, what degree of symptoms they have, if they're hypotensive, some of their chronic comorbidities are here for whatever reason. COPD was selected as one to pay particular attention to. And then solid tumors, if they're solid tumor rather than hematologic, they get points because hematologic is always at higher risk of developing severe complications. Dehydration, whether they were an outpatient or an inpatient at time of presentation, and then their age. And so the more points that you get on the score, the safer you are for outpatient management. So effectively, the more points you have, a score greater than 21 is predictive of you having a low risk febrile neutropenia episode. Okay. The total number of, if you add up the max amount of points here, if you're completely low risk, it's 26. So a 21 or more is predictive of low, but a total score would be 26. And then the second score that was created actually in response to this score, because this score, when it's studied, has variable results across different studies in terms of actual predictive value for predicting severe complications of neutropenia. In some studies, it's excellent. It has like a positive predictive value of 91%, and then some it's 41%. So like a lot of scoring tools, it has its limitations. And so this was created as a clinical index of severity of neutropenia score in trying to respond to that. The major limitation of this score, though, is that it's only validated in solid tumor patients. It does not at all work in hematologic patients, which are often the patients that have febrile neutropenia. So this one looks at the ECOG score, COPD again, chronic cardiovascular disease, a mucositis score, but effectively this translates to not being able to eat or swallow. It looks at your monocytes, and then stress-induced hyperglycemia. And a score of less than or equal to 2 indicates that you're at low risk for severe complications and would qualify you for an outpatient approach to management of neutropenia. So just be aware that these scores exist. If you type them into Google, it comes up with like the MD calculators where you can quickly just click yes or no. So you don't need to remember the components of these or anything like that. But if you're trying to decide whether or not you think someone is appropriate for oral medications or outpatient management, these are two scores you could reference to confirm that you're on the right track. But with the IDSI guidelines basically have come up with a list of reasons why a patient should be admitted. So this list comes from the IDSA guidelines and says that any of these following characteristics, they're high risk and need to be admitted to hospital. Okay. So any patient that received cytotoxic therapy that will result in severe neutropenia lasting for more than 7 days. Okay. If they have a mass score of less than 21, a CI-SNE score of greater than or equal to 3, specifically only for solid tumor patients. And then basically any sign of infection you can find on exam. So if they have severe sepsis, shock, oliguria, oral or GI mucositis, a catheter infection you can find on exam, a pulmonary infiltrate or hypoxia, if they have underlying lung disease, if their cancer is uncontrolled or progressive, if there's evidence of hepatic irritation or renal insufficiency, if they have any of these criteria, they need to be admitted to hospital. So effectively, in order to be managed as an outpatient, you have to be a very well, have minimal comorbidities, have minimal symptoms. It is a very selected patient population that can be sent home on oral agents. So the patients, however, that do qualify for that, the empiric therapy that you would put a low risk patient on who's going to go home for the febrile neutropenia would be a combination of both amoxicillin clavulin, so amoxiclav, as well as ciprofloxacin. So both those agents together, right? In patients that have a penicillin allergy, you can use levofloxacin or moxifloxacin as monotherapy, or you could use ciprofloxacin plus clindamycin in patients with a penicillin allergy. I personally don't love clindamycin because of the association with C. difficile infections. But in patients with a true penicillin allergy, it could be considered. My personal feeling is give them 1 dose of something that's penicillin related in the emerge and see what happens, because most of those penicillin allergies are not real. But I have the luxury of admitting all of my patients, and I'm not in an emerge trying to dispo people as quickly as possible. So those are some alternatives you can use if someone has a penicillin allergy. But ideally, these patients go home on amoxiclav in addition to ciprofloxacin. Okay. So just to remind you of why we're choosing this combination of drugs is that amoxiclav has really good gram-positive, gram-negative, as well as anaerobic coverage. So very broad. I like to tell my medical students it's basically very similar to Piptazo, but oral. It just doesn't have Pseudomonas coverage. So it's an oral Piptazo minus Pseudomonas coverage with really good broad spectrum coverage. And then the ciprofloxacin is providing that Pseudomonas coverage, hopefully. In addition, it is providing atypical pneumonia coverage. So we don't classically think of ciprofloxacin as a respiratory antibiotic, except in patients with cystic fibrosis or other kind of bronchiectasis, complicated lung disease, but it actually does have quite good coverage against all the atypical pneumonia pathogens. So just remember that it does provide that as well. And then levofloxacin can be used as an alternative for the Cipro because it fulfills the same requirements as Cipro was doing it. So at higher doses, the 750 doses of levofloxacin, it has reasonable Pseudomonas coverage. And again, it would provide both typical as well as atypical pneumonia coverage. But your amoxiclav should be covering your typical pneumonia pathogens as well. Okay. In terms of high risk, these are patients you're bringing into hospital. So you're going to choose an IV medication for these patients. And the monotherapy you're going to start with is an anti-pseudomonal beta-lactam agent, okay? So something with pseudomonal coverage, those options would be your penem, so your meropenem or imipenem, Piptazo at the Q6 hour dosing specifically. The Q8 hour dosing does not have pseudomonal coverage. So if you're going to use Piptazo, please use the Q6 dosing. And then ceftazidime is possible. I would say that the top 3 are certainly the ones that are used most commonly. Where I trained at Western, everyone got meropenem right off the bat. Here at HSN, it's kind of more understood that most people start with Piptazo and then advance to meropenem if they don't DEFRS, but you're very safe to choose Mero, IMI, or Piptazo in these patients as your first line of therapy. And then there's some additional things you might cover. You might add to that coverage depending on the patient's clinical exam or their history. So vancomycin should be added in patients that you suspect have a catheter-related infection, even potentially in patients that don't have colonization of MRSA, because these patients are in and out of healthcare frequently and likely have risk factors for MRSA colonization. Remember that MRSA and MSSA pneumonias are increasingly more common pathogens for community-acquired pneumonia. As time goes on, the rate of that being the pathogen identified on bronchoscopy is increasing. So you might want to consider adding vancomycin for pneumonia patients or anyone really, really sick. And then always remember, because it's one of my pet peeves, that even though these meropenem, imipenem, piptazo are big gun antibiotics, they do not give you atypical pneumonia coverage. So if you think someone has a respiratory source, you need to add atypical pneumonia coverage with azithro, cipro, or levofloxacin, something for those patients, if you think they have pneumonia. And then if a patient has mucositis, you may want to consider systemic acyclovir or antifungal coverage. The antifungal coverage for mucositis could start as a swish and swallow type thing. You don't necessarily need to use systemic coverage right off the bat, but just as an additional consideration for patients with mucositis, you may want to consider acyclovir or an antifungal. In terms of duration of coverage, this all depends on whether you isolate a pathogen or not. So if someone is febrile and is neutropenic and you identify their pathogen, then the duration of the therapy depends on the pathogen. It depends on whether you found something that was gram positive in their blood or gram negative in their blood, or whether you found something in the urine. And you would direct your therapy towards that pathogen for the typical amount of time you would treat it in any other patient, okay? If you find a source of infection, so you don't have a microbiology result that's positive, a blood or urine culture that's positive, but you think you have a consolidation on chest x-ray or they have pulmonary symptoms, then you direct the duration of therapy to the source of infection. So if you think that they have pneumonia, you complete a 5 to 7 day course for pneumonia. If you think that they have pyelonephritis, you do 10 to 14 days for pyelo, a UTI, 5 to 7 days for UTI treatment, okay? But if there's no source, you can't find anything on history or physical, and there's no pathogen, all the microbiology studies are negative, then the recommendation would be the empiric therapy for 72 hours. And you can discontinue the therapy at 72 hours as long as they've been afebrile for 48 of those 72 hours. And that's regardless of their ANC. So you do not need to keep these people on coverage until their neutrophils recover. It's whether or not they are persistently febrile or in clinical stability, obviously. So again, 72 hours in total, but 48 hours of them being afebrile, you can discontinue their therapy regardless of their ANC count. Okay. One thing to pay close attention to is catheter removal in these patients. So like I said, a lot of our oncology patients have indwelling PICC lines, central lines of some sort. And so these central lines should be removed in patients with gram-positive bacteremias, especially MSSA and MRSA. They should be removed in patients with pseudomonal bacteremia. And most patients with Candida bacteremia, they should have their central lines removed as well. This one's a bit more debated because most people feel that Candida in these patients come from the gut. But to be on the safe side, anyone with a fungus in their blood, I think you should be taking out any plastic in them that you can take out in order to clear that candidemia. In a patient that's likely to go on to have more immunosuppressant therapy, you want to be sure that that source of infection has truly been removed from their body. Some other considerations that I just want to highlight is that these patients are no different than other patients with infections, other than they're at higher risk of complications. So remember that you still need to treat their infections the way you would with other general medicine or hospitalist patients. So gram-positive bacteremias still need to be investigated and treated in the same way that they are for other patients. So you still need an echocardiogram to rule out endocarditis. You still need at least 2 weeks of antibiotic coverage from the day of negative cultures for these patients. And then gram-negative bacteremia, remember that you do not need a full 2-week course of IV antimicrobials for these patients. E. coli bacteremia, for example, only requires 7 days. And you don't even need to necessarily do 7 days of IV therapy for those patients. As long as you think their mucosal membranes are intact and they're absorbing medications, Cipro has the same bioavailability orally as IV. So an E. coli bacteremia could theoretically go home the next day if they're stable on oral Cipro, and to complete a 7-day course. And the one exception to that would be Pseudomonas in these patients. I would pay a little bit more close attention to, and studies would show you probably could get away with 6 to 10 days for Pseudomonas in a non-immunocompromised patient, but in a cancer patient, I probably would still target 10 to 14 days. But most gram-negative bacteremias do not necessarily need IV antimicrobials and do not necessarily need a full 2 weeks. But please, please, please still treat your gram-positive the way you would with anyone else, to not miss endocarditis or another potential complication of that bacteremia. We get a lot of questions about whether we should be putting these patients on GCSF to stimulate the bone marrow to recover those neutrophil counts more quickly. The IDSA, there's been multiple studies that have looked at this, and there's been no consistent evidence that it improves outcomes or shortens length of stay in hospital. In fact, giving GCSF can actually cause people to have worsening fevers because it can, as the bone marrow is stimulated, that in itself can cause fevers. So it may actually lengthen a hospital stay. So the IDSA currently recommends against the routine use of GCSF in these patients, but on a case-by-case basis, it could be considered in severely ill patients that are in the early phase of their nadir or those with really slow recovery. So if you're really worried about someone and you think they're going to be neutropenic for an extended period of time, it might be something worth considering, but only in select cases. The median time, so some of these patients, the ones that we struggle with most on the ward, are patients that develop persistent fevers. So instead of deferessing, they actually continue to have fevers, and we'll walk through a case. One of the cases ends up being like that. So we'll walk through kind of what to do. But just remember that the median time for people to resolve their fever after you start empiric antibiotics is 5 days for patients with hematologic malignancy and 2 days for people with solid tumor. So as long as the patient is clinically stable, there is no substantial rush to change their antimicrobial coverage, even if they remain febrile for several days. Okay. So again, hematologic, it's 5 full days often before they deferess and 2 days for a solid tumor. So you've got some time to just watch them. And as long as they're behaving well clinically and they're not becoming more clinically unwell, there's no great rush to change antimicrobial coverage in those patients that have persistent fevers. That being said, if a patient remains febrile for around the 4-day mark on broad spectrum antimicrobials, there are some things that you should probably consider. So you might want to consider changing the antimicrobial coverage to have extended coverage, so ESBL coverage. So for example, if they're on Piptazo, you might want to advance to a Miro or imipenem. You might want to add vancomycin or empiric fungal coverage at that point. It's not unreasonable if you have access to an infectious disease specialist to have them involved at that point. Please make sure to repeat blood and urine cultures at the time of these ongoing fevers to see whether or not you can capture a pathogen on subsequent microbiology results. Stool cultures if they're having any diarrhea, specifically to rule out C. diff. And then you could consider a CT of the sinuses and chest to look for fungal infections that are a bit more occult. They don't typically have overt symptoms of hypoxia or respiratory symptoms. And then if they're having any abdominal symptoms at all, you could obviously look at their abdomen or pelvis on CT as well to make sure there's nothing going on there. And then these patients too, just remember that just because they're a cancer patient and the concern that we have about their mortality is most linked to infection, it doesn't mean that they couldn't have an alternative cause of fever. So if someone has been on broad spectrum antimicrobial coverage for more than 5 days and they're persistently febrile, you need to think to yourself, is there an alternative cause of this fever? So for example, could it be their white count recovering? So myeloid reconstitution syndrome, as the bone marrow recovers and the myeloid counts increase, sometimes patients get fever just from that. Could it be the cancer itself? So a lot of cancers, especially hematologic ones, come with fevers. Could it be a DVT? These are all oncology patients at high risk for venothrombotic events, even when they're pancytopenic. A drug fever, Piptazo and penicillin drugs are classically associated with drug fever. So are we causing these fevers, et cetera, et cetera. So just make sure to broaden your differential at that point to non-infectious causes of fever as well. So now that we've kind of talked about, the definition of febrile neutropenia, the patients at risk for this, and what your empiric coverage should look like, let's go back to our cases and walk through how these cases were managed and some specific considerations. So the very first case that I presented was this 42-year-old female with ovarian CA on systemic therapy with carboplatin and paclitaxel. who came in because she was taking her temperature as instructed at home and found to be febrile. When she came into the emergency room, she was vitally stable. She had a documented fever that met the definition for fever, according to the IDSA definition. And her investigations revealed a severe neutropenia with an ANC count of 0.3 or 300. The rest of her blood work was not particularly remarkable and in keeping with someone who had recent chemotherapy. So if you put her factors into the two scoring tools that I reviewed, her mask score is greater than 21. It was actually 26. And she actually didn't have any of the scoring features on the CISNE score, so 0. So she meets the criteria on both of the scoring tools to be low risk for severe complications of neutropenia and is likely appropriate to be managed as an outpatient. So this lady is someone who could safely be discharged home from the emergency department or the cancer center or anywhere else that you're encountering this patient for outpatient management. But there's a few things that I would make sure are going to happen before you manage someone with neutropenia, febrile neutropenia at home. So you need to make sure that someone is going to adequately follow up on the results of those blood and urine cultures. Ideally, you perform a chest x-ray prior to discharge, because if you remember those IDSA guideline criteria, even if they have a pulmonary infiltrate, that would be a reason for inpatient management of this patient. So a chest x-ray ideally prior to a decision about disposition. And then very careful counseling on reasons to return back for reassessment. So although if she was an inpatient and had persistent fevers for up to 4 days, we wouldn't panic. If someone is at home and having ongoing fevers for more than 2 days, I'd like to reassess them. If they develop any localizing symptoms of infection, that'd be another reason for them to be reassessed so that we can direct antimicrobial therapy, duration, and choice towards that particular infection. If they develop mucositis or dehydration, if they clinically worsen rather than improve, those would all be reasons to be reassessed. And then the choice of therapy would be, as I mentioned, empiric therapy for low-risk patients, which would be amoxicillin, clavulin, and ciprofloxacin together. So those scripts were provided to her. Her outcome was excellent. She had blood and urine cultures that returned back negative a few days later. Her chest x-ray was unremarkable, but unfortunately her COVID swab was positive. So likely the cause of her fevers was COVID, and she just happened to be neutropenic from her chemotherapy at the same time. So the patient was contacted again. She had minimal symptoms, and she didn't qualify for any advanced COVID therapy because she had 4 vaccines at this time, and her COVID disease was considered mild in severity. But she received some counseling of what to look for in terms of COVID infections and reasons to return back to the emergency room for reassessment and admission. So her fever was actually probably related to COVID, but it's not unusual for these patients to have nothing come back positive. And then you have a choice of just telling them to complete a 5 to 7 day course of those antimicrobials, or to discontinue them after 72 hours if their fever has gone away for 48. It's just that can be kind of a complicating thing to tell an outpatient. So sometimes, just to be prudent and on the safe side, I'll just have them complete a course of antimicrobials of about 5 to 7 days if I'm sending someone home with febrile neutropenia. So the second case was a much more complicated presentation of febrile neutropenia. So this gentleman, again, is a 64-year-old with myelodysplastic syndrome. So his neutropenia is related to his medical condition. It is not related to any systemic therapy that he's on, because he's not actually on any therapy at this point in time. He had failed all management for his MDS and was booked for an allogenic stem cell transplant in 3 weeks' time in Ottawa. He was a relatively well gentleman with a few comorbidities, some mild hypertension and type 2 diabetes, managed on oral agents. He had come in for the same reason as our first lady. He had just been checking his temperature at home as he'd been instructed to do, and was found to be febrile. And his history and physical exam was quite unremarkable. In the merge, he was found to be mildly tachycardic with a heart rate of 99. Temperature was 39.1, so it met the definition of fever. And then he was found to have a severe neutropenia with an ANC count of 100 and a pancytopenia otherwise, very much in keeping with his baseline counts for his MDS. This is a gentleman who is almost at all times neutropenic to a certain extent in the community. And his other blood work was actually quite unremarkable, except for his glucose being elevated at 17. So again, this is a gentleman you're trying to decide, does he need to come into hospital? Can he be managed as an outpatient? So if you want to, you could reference those scoring tools. So his score on the MAS score was actually 24, which actually indicated that he was low risk and theoretically could be managed as an outpatient. Remember that you cannot calculate the CISNE score in patients with hematologic malignancies. So it's only validated in solid tumor patients. So I could not use that score for this gentleman. And so the question is, what is the plan for this gentleman? But if you go back to the IDSA guidelines that kind of look overall at whether or not a patient should be managed as an in or outpatient, I would argue this man should come into hospital for two reasons. So number one, the first criteria is specific to patients who are on cytotoxic therapy and patients that are going to be profoundly neutropenic for more than 7 days. So this man's not going to be profoundly neutropenic for more than 7 days because of therapy, but he is going to be persistently neutropenic for potentially indefinitely until he has a stem cell transplant. And so I kind of equate that as the same thing as that first criteria. And then the second thing is that he has currently uncontrolled or progressive cancer. His cancer is not currently treated. It continues, it is still active. And so based on those two criteria, I would argue he requires an inpatient stay in hospital. And so this man was admitted under the oncology service and was placed on Piptazo for Empiric coverage. And then the chest X-ray that was ordered at time of admission did interestingly reveal new bilateral pulmonary infiltrates. So I added azithromycin for atypical coverage of pneumonia. So now he's on Piptazo and azithromycin for pneumonia coverage. His COVID swab was negative and his blood cultures were still pending at this time of the admission. So on day 2 to day 3 of his hospital stay, he remained persistently febrile, but vitally entirely stable, felt very well, wasn't hypoxic, was just suffering intermittent fevers associated with rigors, and his blood counts remained stable. So they weren't really improving, but they weren't worsening. His ANC count remained around 100, so profoundly suppressed. His blood cultures eventually returned back negative. And because on day 3, day 4, he was still persistently febrile, his antimicrobials were adjusted to meropenem, and vancomycin was added because of the pneumonia and the potential possibility of MRSA pneumonia. On day 4, when he remained persistently febrile, a CT of his thorax, sputum cultures, and serum galactomannan was ordered. And interestingly, his CT thorax revealed significant new hilar cervical lymphadenopathy, as well as some patchy consolidations and nodules in the chest. So substantially changed from prior imaging with quite concerning features for possibly something new going on. So on day 5, he was still febrile. At this point, he's on vancomycin, meropenem, and azithromycin. And so respirology was consulted for consideration of bronchoscopy. And at that point, I initiated a workup for alternative causes of fever. So for example, I repeated a bone marrow biopsy to rule out that his MDS had not transformed into an acute leukemia, which could be a cause of fevers. And then also there was concerns based on all the lymphadenopathy seen on his chest imaging that this may be a new lymphoma. So I did the bone marrow biopsy to see whether or not there was potentially signs of lymphoma in his bone marrow. I also ordered ultrasound Dopplers of his legs at that point, a CT of his head and sinuses just to complete the workup to make sure there's nothing intracranial causing fevers or in the sinuses causing fevers. And then IR was asked to biopsy one of the cervical lymph nodes to assess what the potential etiology of those lymph nodes were. And then there was a good review of medications to rule out drug fever. So initially he had been on Piptazo. Piptazo is very highly associated with drug fevers, but at that point he'd been switched to meropenem, and the vancomycin was relatively new. So it was unlikely to be a drug fever, but always something to keep in mind in these patients that are persistently febrile despite good antimicrobial coverage. So on day 6 and 7, he remained persistently febrile. Respirology did their bronchoscopy. And at that point, they recommended coverage for PJP pneumonia and fungal pneumonia. So we added Septra and caspofungin. So again, just to remind you, at this point, he's on meropenem, azithromycin, vancomycin, Septra, and caspofungin. So 5 different antimicrobials with quite broad coverage and still persistently febrile. And IR has completed his lymph node biopsy. So by day 18, the patient is very frustrated with a lack of answers and his persistent fevers. He's very concerned that his current illness will delay his stem cell transplant, and he keeps telling us just to discharge him home so he can go to Ottawa, get his stem cell. But we try to carefully counsel him that we need to figure out whatever's going on in his chest before he goes for his stem cell, because obviously he'll be profoundly immunocompromised during his stem cell transplant, and whatever's going on could potentially lead to much higher fatality rates if we don't figure it out. And then on day 14, I got a phone call from the pathologist who was looking at the sample from his lymph node biopsy, and he actually had seen some acid-fast bacilli in his cervical lymph node, which was a complete shock to all of us. So does this gentleman have reactivated tuberculosis or some sort of non-tuberculosis mycobacterium? So at that point, plans were actually made to try to discharge this man home, to try to isolate him at home until we could do further respiratory investigations. But unfortunately, on day 16 of his hospital stay, he tested positive for COVID-19 pneumonia, which was caught during an outbreak on our oncology ward. So he became hypoxic, remained intermittently febrile. He was unvaccinated and refused any advanced COVID-19 therapy, such as remdesivir. It'll never cease to amaze me that someone is okay with a stem cell transplant, but not remdesivir or vaccine. But this gentleman adamantly refused any care for his COVID-19, told me he didn't believe in COVID-19, and remained, unfortunately, on our ward until he was no longer hypoxic on day 21. So on day 21, when he was no longer hypoxic, he was discharged home with follow-up with respirology.
Okay.
Sorry, I'm not sure if someone has a question. I don't think so. So he was discharged with follow-up with respirology for his BAL from his bronchoscopy results, as well as PCR results, to see whether they could further classify what type of acid-fast bacilli this was. And on the advice of respirology, no antimicrobials were provided at time of discharge. He had completed a 3-week course of coverage for almost everything that could be in the lungs. And so they recommended no further coverage. And the stem cell team in Ottawa was made aware of the test results, and his transplant was placed on hold, much to his frustration. So what was interesting about him is his bronchoscopy BAL actually never grew anything, even waiting quite a long time for those cultures to result. It never grew anything. And so Dr. Addison, our local respirologist, repeated a bronchoscopy with biopsies, which was tricky to arrange in this patient because we had to obviously give him platelets ahead of time and that sort of thing. But the biopsies ended up revealing a non-tuberculosis mycobacterium, thankfully. So he did not have disseminated tuberculosis. I shouldn't say disseminated, reactivated pulmonary tuberculosis. So he's currently receiving therapy for his non-tuberculosis mycobacterium, and hopefully will proceed with a stem cell transplant once his treatment course is complete. So this is the opposite of the first case in terms of a gentleman who has high risk features for complications and what to do in terms of a diagnostic process if someone is persistently febrile while on multiple antimicrobials. So just to summarize some of the things we've talked about today. So febrile neutropenia is a common concern facing oncology patients. If it's left unrecognized, it carries a high mortality rate. Certain patients, when very carefully selected, can be treated as outpatients on oral antibiotics. Often a pathogen or clinical site of infection cannot be identified, and the coverage is empiric. And empiric coverage can be discontinued before completing a full course if a patient's fever resolves even before the ANC recovers. That's a big takeaway point. And if the pathogen, however, is isolated, the therapy should be directed both in coverage and duration to that causative agent. So if you find out it's a pneumonia, you should be treating them appropriately for pneumonia, regardless of their fevers. And then if the fever is persistent, please continue to investigate for alternative causes to fever, both infectious, atypical infections, or non-infectious causes for fever. So that's all I have for today. Thank you so much for listening. I'm just curious if anyone has any questions.
If anyone has any questions.
Hello, I have a question.
Go ahead, Dr. Casson.
Yes, I'm the only non-clinician in the group. I'm the pathologist. At the beginning, you mentioned about avoiding rectal examination. I think close to getting the first patient. What's the reason for that?
So the reason to avoid a rectal examination in someone with neutropenia specifically is there's a concern anytime anything is inserted in the rectum, whether it be your finger, a swab, anything into a colonoscopy, a scope, anything into the rectum, is that you'll actually disrupt the mucosal membrane and allow the pathogens that sit in there to enter the bloodstream. So it's you may actually provoke a bacteremia by examining that area. So some of these patients are also counseled not to floss during their neutropenic phase for the same reason, because as they disrupt the mucosal membrane in their gingiva, you may introduce bacteria into the bloodstream. So there's a set of things that just increase the risk of actually causing a bacteremia. And the one that we would be doing to the patient rather than the patient doing to themselves, hopefully, is a digital rectal exam.
That means also that endoscopy is out of the way.
Yes, so people will not get endoscopic evaluations until their neutropenia is resolved. In fact, we struggle with this, especially with all the new immunotherapy that's being used for cancer patients, specifically solid tumor patients, often come with severe colitis as a complication of that therapy. And it's often very helpful for our gastroenterologists to do either a flex sig or a colonoscopy to try to determine whether this is an inflammatory or infectious colitis. And they won't touch these patients until their neutrophils are at least 0.5 or 500. But in terms of platelets, that's the other reason they'll often hold off on doing endoscopic evaluation, but often we can get their platelets up with transfusion. So neutrophils are really the thing that does prevent our GI or general surgery colleagues from investigating these patients.
Thank you.
No problem.
Anyone else?
Hi, it's Victoria Smith. Thanks so much for your presentation. Question for patients who are presenting to the Emerge with a history of cancer and on chemo, but not found to be neutropenic. Are they managed basically just as a regular patient? Or do you have any special considerations for that?
Yeah, I would manage those patients as a normal patient that has an infection, but with more close attention to whether you anticipate that they are going to have a drop in their count. So it used to be that an anticipated drop within the next 7 days to a neutropenic phase would qualify them for having febrile neutropenia, even if they had a normal neutropenic count. That's kind of been taken out of the most recent iteration of the IDSA guidelines. I mean, I think treating an oncology patient without neutropenia the way you would any other patient is fully reasonable, as long as they're a reliable patient that's willing to come back for reassessment if their symptoms worsen. And so I would just be extra cautious to counsel them to come back if they have persistent fevers, to be reassessed potentially with blood work by their oncologist in the coming days. And you probably would be safe to give them some coverage, like somebody who comes in with a fever that you otherwise may have not offered antimicrobials to. You might offer it to someone who is just starting their counts dropping. Like if you expect their counts to go neutropenic in the next 2 to 3 days, I don't think you would at all be faulted for prophylactically giving them an antibiotic when someone who was not an oncology patient, you would just send home with supportive management.
Great, thank you. Yeah, that's great, thanks.
It's in the absence of any other questions. Any more questions? If not, we wish to thank you very much for this excellent presentation.
Oh, thank you for having me. I appreciate it.
Okay.
Thank you.
Hearing nothing further, thank you very much, Dr. Jackson, for coming and presenting on this topic for us. Just a reminder, our next set of rounds are September 30th, and it's Dr. Champion and Dr. Gibson presenting on common breast diseases.
Thank you.
Thank you so much.
Thank you.
Thank you.
Hey, no problem. Thank you.
All right, take care.
Yeah, I sent you an email. I need a copy of the presentation for accreditation.
Oh, sure. Okay, I'll get it to you.
Okay, perfect. Thanks.
Thanks. Bye.
Have a great day.
You too. Bye now.
Okay, bye.